Good morning, Prof. McPhee, Prof. Primrose, members and guests. Adjuvant preoperative therapy is controversial in rectal cancer. It is good, as we all know, because of a better control for local disease, downstage the tumor, make it operable, preserve the sphincter, increase survival rate, and also treat any micrometastases and sterilize lymph nodes. When we say adjuvant preoperative therapy, we refer to radiotherapy, short-course radiotherapy for rectum, long-course chemoradiotherapy for rectum, and long-course chemotherapy for colon, as is part of the Foxhole trial. We all know as a background that adjuvant preoperative therapy, as we just mentioned now, has non-specific signs and symptoms such as nausea, vomiting, diarrhea, weight and appetite loss, fatigue and malnutrition. But we don't know what are the real physiological effects on the human body. Chemoradiotherapy can cause damage of the body microcirculation, cause tissue hypoxia and cellular death. And this can lead to pulmonary toxicity, cardiotoxicity, impaired oxygen delivery, and end organ failure. And it also can cause some localized side effects such as radiation enteritis. So the hypothesis is just straight and simple that if APT has a significant effect on cardiopulmonary function, body composition, physical nutrition status, health-related quality of life, and inflammatory markers, this will subsequently lead to having an increased risk of having cardiopulmonary events, anastomotic leak and dehiscence, malnutrition, chest infection, sepsis, etc. And this, of course, will lead to increased peri- and postoperative mortality and morbidity. So our aims were primarily to measure any changes in cardiopulmonary reserve and also to measure changes in body composition, physical nutrition status, health-related quality of life, and inflammatory markers. All these changes are measured before and after the chemoradiotherapy, this is all before surgical resection. So this is a prospective observational pilot study done on patients with advanced rectal cancer deemed to have to be needing for adjuvant preoperative therapy to downstage the tumor. And we have powered this to the primary aim, which is change in the cardiopulmonary reserve. We have recruited 36 patients. We use the same tools before and after APT. This is all before surgical resection. We have used cardiopulmonary exercise tests to measure cardiopulmonary reserve, bioelectrical impedance analysis for changes in body composition, physical nutrient changes were measured with anthropometric measurements and 2 validated colorectal questionnaires, as well as plasma markers for pro- and anti-inflammatory markers, as well as CRP and albumin. CPX test, patient go on the bike for about 10 minutes, ECG electrodes and mouthpiece attached. A number of parameters can be obtained from this test, but the most important one relative to surgical practice is VO2 max, which is the maximum oxygen consumed by the body, and the anaerobic threshold, where the body starts to use the anaerobic mechanism to obtain oxygen, as well as the ventilator equivalent ratio for CO2, which is a measurement of the pulmonary dead space or the unused alveoli. So the more the numbers of the VCO2 is the bad pulmonary function. Bioelectrical impedance analysis to measure intercellular water, extracellular water, total body water, and fat-free mass. It's easy and safe, and it's reliable because we use it on the same patient. Anthropometric measurements, such as tricep skin fold, hand grip strength, and mid-arm circumference, in addition to body weight, height, and body mass index. Plasma samples measured by ELISA to measure pro-inflammatory markers and anti-inflammatory markers, as well as CRP and albumin. 2 colorectal validated questionnaire. So we have recruited 36 patients, and all of them have completed the test, more male than female, with a mean age of 63.6. If we split the cohort of patients into 2 groups, radiotherapy group were 12 patients and the chemoradiotherapy group were 24 patients. We consider this as non-neutrally distributed data, and we use non-parametric tests to assess the results. So CPX result, there has been a significant decline in the VO2 max as well as the AT. So this is indicating a poor cardiovascular function. And also there has been a significant increase in the VECO2. So there's more pulmonary dead space, more unused alveoli, more or worse pulmonary function. And if we split the cohort of patients into 2 groups, the blue line represents the chemoradiotherapy group and the green line represents the radiotherapy group, you can see all the results are the same. Apart from the radiotherapy-only group, the short-course radiotherapy group, which did not have any effect on the pulmonary function, as what you can see in this line there. BIN and anthropometric results. You can see the significant decline in total body water, mid-arm circumference, tricep skin fold, grip strength. And again, if we split the cohort of patients into two groups, they all significantly reduced with a reduction in their fat-free mass. Cytokines, we have seen a deranged pro-inflammatory markers, especially with IP10, RANTES, TNF, IL-1, and also some deranged anti-inflammatory markers, as we can see in MIF and IL-10. There has been a deranged CRP with a reduction in the plasma albumin. All health-related questionnaire, all health-related quality data were significantly reduced. So as a conclusion, patients who finish adjuvant preoperative therapy and waiting for major resection have an impaired cardiovascular function, as clearly seen in the VO2 max and 80. They have a poor pulmonary function with increased pulmonary dead space. They are fluidly depleted. They have less lean body mass, less muscle bulk to tackle anything. They have poor physiological, nutritional, and psychological well-being. And they have deranged cytokines, CRP, and albumin. And this might play an important role in systemic inflammatory response or counteracting anti-inflammatory response. So what do we do for these patients? We operate on them, and we expect not to have any mortality and morbidity. So the message is very clear here that APT is important, as we clearly mentioned in this study, but it has a significant impact on the body physiology. And this is linked to the peri- and post-operative mortality and morbidity. And all what we're asking for here is a period of optimization between the finish of the therapy and the surgical resection, as too big insult within a short period of time is not good. Thank you very much.